Hello everyone, my name's Anna and I'm a community midwife. I've put together this pop-up lecture to help midwives refresh and think about managing postpartum hemorrhage at home birth or in those lower risk environments. So the purpose of this pop-up lecture is to have a look at the causes of postpartum hemorrhage, categories, the management that we should take in these low risk settings, consider the scope of practice, and I put some useful links on at the end. So the reason that we worry about postpartum hemorrhage so much is the term that we use for a reduction in blood volume is hypovolemia, and that causes a reduction in cardiac output, which reduces blood pressure. That means that the circulating oxygen is reduced drastically, and that can lead to kidney and liver failure, organ failure, acute respiratory distress syndrome, the IDS that's noted there, and Sheenan's syndrome, which is actually the pituitary gland necrosis due to the lack of oxygen and causes significant problems there. So it really does lead to long-term health implications for previously healthy women. Disseminated intravascular coagulation, DIC, that is a reduction in clotting factors, which then causes an increase or causes the hemorrhage to increase. And again, it's a very serious condition that we're trying to manage and avoid in the emergency procedures that we put in place. The categories of PPH are interesting to note and have relevance as far as management is concerned, but the really important thing to remember here is that it's whether the woman is symptomatic. So if she's being affected or showing signs that she's been compromised by lack of loss of blood, a hemorrhage, then in some ways these terms are academic. But we can see here that a minor PPH is between 500 and 1,000 mils. Moderate PPH is between a litre and 2 litres, and severe is greater than 2 litre blood loss. But really any hemorrhage that is affecting the mother, the woman, is of significance. Causes of postpartum hemorrhage then can be categorised by using the 4 T's. So that's tone, trauma, tissue and thrombin. So as we can see from this diagram, the thrombin, or the lack of clotting factors, only accounts for 1% of postpartum hemorrhage. Although it's really serious, it's also a very rare event. 9% of postpartum hemorrhage is caused by retained products of pregnancy, so that's the T for tissue. 20% is caused by trauma and bleeding in the genital tract, so that T is for trauma. And the vast majority of cases of postpartum hemorrhage are caused by lack of uterine tone, 70%, as you can see here in this illustration. And so that's really what we're going to concentrate on in this pop-up lecture, because it is about managing these situations and transferring the woman to an environment where it can be managed better or most effectively, and that won't be at home. So it's looking at emergency procedures that we can put in place while we're managing that transfer into the acute setting. The RCOG, it's the Royal College of Obstetricians and Gynecologists, talk about the components of management of a postpartum hemorrhage, and I've put this here in a flow chart. But actually, all of these things are happening simultaneously. They're all happening at once, but it's easier to look at and break it down in these different components. So look at communication, resuscitation, monitoring, investigation, and controlling the bleeding. All of these things, as I say, are happening at the same time. So we're looking at the scenario here of a woman has birthed her baby at home, and there's had active management of the third stage, and that third stage is complete. The woman continues to bleed after the placenta has been delivered, and we're looking at the cause of this as being an atonic uterus. And remember that 70% of cases are postpartum hemorrhage. So this, along with trauma, are going to be the most likely scenarios that we're dealing with in relation to PPH at home. So calling the emergency services, dialing 999 in many units across the whole of the UK, 999 is the go-to for summoning emergency help. After you know that a paramedic is on the way with an ambulance, you need to be very specific. For those of you who haven't called an ambulance out before, they do have a pro forma or a script, things that they ask you. You need to be very clear that it's an obstetric emergency, that you need a paramedic and you will need an ambulance because you will be transferring into hospital. Remember, in the home, if you're there on your own, you're the first person to arrive. You need to think about speakerphone or actually getting somebody else to talk into the phone or to call the emergency services so you can get on with actually administering that emergency care. Do not delay in getting paramedics on their way to you. If they're not needed, everything's under control by the time they get there, they can always stand down, but always get somebody coming to you. Things to consider, particularly in the area that I work, sometimes phone signal isn't that good. It's important that we think about these things while we're preparing the woman for and discussion around home birth in the antenatal period. It's really important that maybe they have a phone line that's working, a landline, and things such as a torch. Head torches are really handy for home births anyway. Things like asking the woman to have a torch to hand and can be really useful, and making sure that you've had a very comprehensive discussion with the woman and her family and partner beforehand, and that you record any discussion of those issues in her notes so that it's documented. The situations that I've been in when I've been out to attend women at home who perhaps don't meet the criteria that we would recommend home birth as being safe, so previous postpartum hemorrhage or for example is relevant to what we're talking about here. It's actually much easier if that discussion has taken place in the antenatal period, so everything is in place and people are prepared. And I think that's really important, and an important thing to discuss with the woman is explaining the limitations of the service before she actually gets into labour. The observations that you're going to take, the most useful ones: respiratory rate, pulse, and blood pressure. At home, you haven't necessarily got an oximeter for checking oxygen saturation levels, but visual observations are very useful. Remember that a woman will compensate really well for quite a long period of time after delivery. They've got an increased blood volume during their pregnancy, and they really can compensate well. So they can then all of a sudden deteriorate really rapidly. So it's important that you preempt that deterioration with prompt intervention. So taking observations every 15 minutes, if possible, is really useful. We need to stop the bleeding, and following these simple steps can manage the majority of postpartum hemorrhages. Rubbing up a contraction, administering a second dose of either 10 milligrams of oxytocin, which is syntocinon, or an ampule of synthometrin. Consider putting in a Foley's catheter. It's really important that stays in, so an indwelling catheter that ensures that the blood is empty, and it also means that we can assess urine output later on. If possible, put the baby to the breast. Again, natural oxytocin to help the uterus contract. And as I mentioned, in the vast majority of cases, these measures will successfully control the bleeding. Remember, in the home environment, you're really trying to stabilise the woman until help arrives. We want to transfer that woman into hospital. So these other interventions are all potentially possible, but you may have to wait until the paramedic team arrive. So IV access if possible, and I have a video included in this later on just to remind you the principles of cannulation and siting of Venflon. Remember, the paramedic team are on their way and they're really good at putting cannulas in, so you may want to wait until extra help arrives. Ergometrin in an ampule can be given as an IM injection, and it's better to give it IM rather than IV if access isn't available. You have got the option of bimanual compression. It can be applied as an emergency procedure, again until help arrives during transfer to hospital. However, it is really painful, and it's really important that you tell the woman what's happening before you actually do that. It also is quite a hands-on procedure, so you need to make sure that you've tried everything else before you get to that point. There should be an IV infusion of oxytocin running whilst you transfer into hospital. This is the video for IV cannulation, and I'll let you play that for yourself. It's a really useful one, and there's also a really short version which you can find for yourself on YouTube. So these are my thoughts about scope of practice, and recognising and taking appropriate action and not delaying in summoning help are two really important elements. Also, consider who's available to help and what they can do. For example, a partner can make the phone calls, the student midwife can act as a scribe. There's lots of things that people can be asked to do even though they're not clinically trained or qualified. Communication with the woman is really important, so even just reassuring her is something that other people can do as well. And when we talk about summoning help, remember also that I would be contacting the labour ward. Once you know the paramedics are on the way, I will be contacting labour wards, letting them know what's happening, letting them know that you're going to be making your way in. And also, if needs be, you could have somebody on speakerphone just helping you, just guiding you, talking you through. Also, it's important that you tell them perhaps to make sure the second midwife is on the way if you're on your own. Just keeping people informed exactly of what is going on. So sensibly then, for as much as possible, lay the women down flat, maybe with slightly elevated tilt with pillow under bottom if you can. Try and make sure that there's room to move around, and it's really essential that you keep her warm. It's quite possible that she will be going into shock, so keeping her warm is really important. If you've got a watch or a timer stopwatch, that's a really good thing to have running. Know how quickly time passes when you're in these emergency situations, so it's quite nice to have a timer going just so you can accurately assess when and where things are happening. Count out the swabs that you're using with another person. It doesn't have to be a qualified person, but just count out the number of swabs you've used and just write it down. And when I say document, I'm just meaning on a piece of paper or something that is to hand. It can be useful to use swabs for packing purposes in cases of trauma while you're waiting for somebody to come and you need the extra pair of hands and you don't feel that you can suture in those circumstances. Then swabs can be used for packing the trauma and then waiting for help arriving. Remember to keep those swabs and pads, so the Inco pads, the swabs, the maternity pads, just keep them. Put them in a clinical bag and take them into the hospital with you. That will help with estimating the blood loss. Take the placenta with you as well. You've obviously given the placenta a quick check just to make sure that it's complete, but it's really useful to take that into hospital with you as well. Notes and record keeping, of course, is really important. But what's more important is you carry out the emergency procedures rather than worrying about writing contemporaneous notes. You need to appoint a scribe if you can. Again, somebody that's not qualified can write down timings and events. And also, it's really important that you actually have carried out the procedures. You just write the notes up at the earliest opportunity after that event has happened and once the woman has stabilised. And lastly, it's really important that you have a debrief with your colleagues that were there, with people that perhaps can give you some advice and look at what happened, why it happened, the actions that you took, what was good about it, what could be improved. I think it's really important to just be able to go over what happened and to just review things just for your own development. So this is a rather dodgy, not very clear printout flowchart from the prompt course. This is a management of a major postpartum hemorrhage. It's a really nice flowchart algorithm looking at that, and you can see that when you get to stop the bleeding, some of those things we'll have available in the home setting and some of those things we won't. So we just need to take emergency action to stabilize the woman, to try and control things to the point of what the confines of the situation we're in, and wait for help to arrive. There's a couple of links that are interesting: the RCM, how to manage postpartum hemorrhage, and also the World Health Organization's advice on PPH as well. So we'll finish here on this last diagram of somebody undertaking bimanual compression. I hope you found this pop-up lecture useful. Hope it's given you a refresher for some of the techniques and some of the emphasis that we need to use in those home and low risk settings. Remember, it's all about emergency procedures, stabilizing the woman and summoning help while waiting for help to arrive. So try not to be too anxious about needing to cannulate and get everything done all on your own. It is about taking those emergency measures whilst you're waiting for help to arrive. So I hope that you found that useful.